There we go. Hi, everybody. My name is Katie Powell, and I am a staff member at the Honors College and one of the advisors for the Advisory Committee on Service and Social Justice. We're excited to have you join us today. I would also encourage you, if you're able, to turn on your camera so Dr. Zielinski can see your wonderful faces. I totally understand if you can't, but we'd love to engage as much as possible in this virtual world. We still have a few more people coming in from the waiting room, so they'll be joining us soon, but I did just want to turn it over to kind of the organizer of this event and one of our primary members of the advisory council, Smit Patel.
Nice. So I don't want to take up too much time because Dr. Zielinski has a great talk and her work is very amazing. I just want to give a quick introduction as to what she does. So Dr. Zielinski is an assistant professor and a clinical psychologist in the Department of Psychiatry and Behavioral Sciences at the University of Arkansas for Medical Sciences in Little Rock. She directs the Health and Legal System Lab, a diverse group of scholars and clinical trainees focused on intersections among trauma, mental illness, addiction, and the legal system. And most of her work has focused on justice-involved women, most of whom are survivors of sexual and domestic violence. And this is just the tip of the iceberg. She can tell you a whole lot more and will tell you a whole lot more about the work that she's doing. Moreover, she obviously, as a professor, trains other wonderful professors and students in her lab. And she's, fun fact, also a graduate from the University of Arkansas, Fayetteville. So this is going to be exciting. Thank you so much for talking to us today, Dr. Zielinski.
You are very welcome. Thank you for such a kind and warm introduction. I'm very excited to be here with y'all today. And like I said, see some familiar faces. Dr. Anna Bridges is on, who has been a longtime mentor of mine. So that's very exciting. And also some graduate students that are in the program that I trained in. I'm going to share my screen here. I hope. There we go. Oh. So when Smit reached out, he asked me to talk a bit about my lab and kind of my journey to being at the point where I am running my lab and kind of what has led up to that. So that's what I'm going to be focusing on. As Smit said, my name is Dr. Melissa Zielinski. I'm an assistant professor and clinical psychologist down on the other side of the state, down in Little Rock at UAMS. You've heard the name of my lab. I would just also mention I chair education production for the International Society for Traumatic Stress Studies, which has a virtual meeting that's ongoing. If you're interested in these kind of topics, join us to learn more. My program of research really focuses around what behavioral health interventions work in legal settings such as prisons, and increasingly on the question of how do you get things done there. Because, and I don't expect you to be able to read this at all, I put this diagram up here to kind of show the many, many branch points within our legal system and the many, many ways in which it's extremely hard to understand, much less imagine how you might get health interventions into a system like this. And so I'm not going to focus a ton on background, but I wasn't sure how familiar that everyone on the call tonight would be with this. And just wanted to give a little bit of context for my work. So mass incarceration in the US has been an increasing issue over the past 4 decades or so. You can see the US is, trend line in terms of the number of people that are incarcerated is basically an increasing vertical line. Whereas if you look around other countries across the world that we often get compared to, you see flat lines primarily. And so this is really, for us, both historically unprecedented. If you look back backwards at the US's prison population over time, like you see in this chart, which is pretty much, again, showing that straight up incline with a little bit of a decline lately, as well as internationally exceptional. So we're first in the world in terms of the number of citizens incarcerated per capita. And if you think about Arkansas, so this came out this past year, it is a chart that shows changes in the prison population 2012 to 2017. And in the green bars that are at the top, you see that the trend kind of nationally across most states, right, is that the population is decreasing. In some states by a sizable amount, up to 40%, in Alaska almost. Arkansas, we're on the very bottom, in the dark blue bottom on the bottom. We've actually increased the most, almost by double the next state. And so this is a really relevant issue in our state, as well as nationally. And so that's just a bit of context. So I really formulated my talk, Schmidt, around your email. You said, you know, folks would be interested in hearing basically about how I got to where I am, you know, how I decided upon the focus of my lab, and then a bit about research, and then try to leave lots of time for Q&A at the end. So I'll start with kind of the journey to becoming a clinical psychologist. And I think I wanted to highlight a couple of themes that I've just kind of gotten to reflect on recently. I think for me, one theme that you'll see stick out is really the connections between practice and research, and how those repeated links really, I try to have it inform everything I do. And then of course, research and practice inform theory, which helps you move forward in both research and practice. I think the other thing that I've been reflecting on, and that maybe will become true as we go across the talk, is I really trained first at the individual level, thinking about how do we do things for individual people to help. So people who are incarcerated, oftentimes in my work. And now really starting to focus on some of the outer levels of the socio-ecological model, and eventually hoping to get up to public policy, but not quite there yet. So that's a goal. But to talk about kind of the journey to becoming a clinical psychological scientist, I've got to start back with some of my formative experiences. So I am not from Arkansas, I'm from New Jersey, born and raised, and grew up in northern New Jersey, about an hour outside of New York City. And I'm going to start my story a little ahead of that to not drag you through childhood, but went to school at the College of New Jersey, which is in Ewing. It's just outside of Trenton, the state's capital. And so in the bottom right of your screen is our psychology building that I spent lots and lots of time in when I was at school at the College of New Jersey. And my research practice connections started all the way back then. So I actually worked, and this is just, something I had an interest in. I worked as an emergency medical tech throughout college. And, you know, I think I was at that time debating between medical school and what am I going to kind of do going forward. And I've had an interest in traumatic stress for a long time, and just really, you know, cherish the direct patient connection, as well as kind of the culture that came with EMT work. But at the same time, I started to get involved in research. So I chose a psychology major, and for whatever reason, I've been one of those people all the way back to high school that would have, there are probably some of you like this on the call, I would have like 400 browser tabs open whenever I did a research paper where I'd see an article, and that would make me interested in another article. And before I knew it, I could write a paper on some other topic than the one that I had originally set out to write, right? And so I got involved in lots of different research labs. I started in Dr. Candace Firings, who's, the picture's a little blurry there, but she was my amazing undergraduate mentor. She ran a romantic relationships research lab, which was an interesting start for me because it was a qualitative lab. And with qualitative research, where you interview people, you get these really rich perspectives. And so very different topic than I work on now. But that was really formative, I think, in my way of thinking about wanting to understand kind of rich phenomena. But I also got to do and pursued and sought out other research experiences outside of my primary lab, including kind of on the basic side of things, doing research. I can claim to have once done research on manipulating Jell-O to see how much perceptions of how much food there was influenced craving and satisfaction with that. And that got me some experience working with psychophys. So I was having this like joint, essentially, experience working in the EMS world and with directly with patients and also with research. And so, you know, couple of years into that, I'm getting close to the end of college, as some of you will probably be soon or are probably right there already, and was at a choice point of, okay, am I going to go to medical school or am I going to go to graduate school and pursue a PhD? And for me, my wanting to focus on research while keeping the clinical practice really won out. And so I went from the College of New Jersey up to U of A, where you all are now. And so if anyone is interested in clinical psych on the call, what you'll find out as you approach that process is you interview all over the place. You look for a good mentor match, find someone that you want to work with, apply everywhere, and move to get the experience you want. And so my doctoral training I did at the U of A from 2011 to 2016. If you do the math, you'll figure out I'm very early career still at this point, just a couple of years out. And I did a clinical internship. That was how I came down to UAMS. It's always the last year of doc programs in clinical psych here at UAMS in 2015. Graduated, stayed for a postdoctoral fellowship that was heavy research from 2016 to 18, and then joined faculty down here in August of 2018. So that's kind of my path. Along the way, again, formative experience being kind of a combination of research and practice. So I worked with Dr. Vayu as my primary mentor at Arkansas, doing a lot of lab-based research on kind of emotion-based constructs at the time. And then my fellowship director, Clint Kiltz, kind of swayed me over into the addiction world over time, where I'm kind of increasingly focusing. But there were some other formative clinical experiences along the way. And so a huge one, and Dr. Bridges, who's on the call, knows this because she's the clinical supervisor, was the clinical supervisor for this. So I had a clinical placement in my third year of graduate school. That was at the Peace at Home Family Shelter, which is a domestic violence shelter in Springdale. And as a part of that placement, started running a group at the Northwest Arkansas Community Correction Center, which you all may not know where it is, but it's like a stone's throw off of campus, pretty much right downtown is a correctional facility. I had driven by it lots and lots of times without realizing it was there before starting to volunteer there. And so if you look for it, you'll see it. But this is a women's correctional shelter, or a women's correctional facility. And we ran a group that was focused on helping women recover from sexual violence. And this was really where my research and clinical integration, I think, started to hit again. So as a part of that, Dr. Bridges and Dr. Marie Carlson, who was a graduate student at U of A and is now in Sweden, invited me to start working with them on a research project related to this group. And so that was really, I think, the magic that I haven't kind of looked back from, is now getting to, really work on things that in research that are really practice-based issues. So integrating the practice and the research and thinking about how do we use one to benefit the other. Along the way, I picked up in this transition from U of A to UAMS, a really amazing training experience that was out of Brown that helped give me additional training and resources to do work within the justice system. And that supplemental piece really kind of helped me move forward. So moving down here to Little Rock, along the entire way along the way, I've been a volunteer within Arkansas's Community Corrections Division, and when I moved down to Little Rock, became a volunteer within the Department of Corrections, so that I could run groups myself and do that in an ongoing way. So I worked with a nonprofit down here called Hope Rises, which focused on helping women re-enter the community from incarceration. And we ran programming out of the Hawkins unit, which is about 25 minutes outside of Little Rock, in a program called Think Legacy that also was focused on helping women prepare for reentry. And over time, and I won't spend a lot of time here, I will just say, that if you look at that diagram of the justice system, how many branches and twists and turns there are, have really over time tried to get experience in other kinds of settings. So drug treatment courts being another example, and eventually jails, reentry, and things like that. But for me, the story has become and has continued to be basically how do we use research and practice kind of in tandem to inform health interventions that can reach people that are incarcerated and people that are marginalized, and that we can help in that system. And I've really focused increasingly over time on how do you do it, as opposed to like what works, if that makes sense. Which has really led me to how do you build capacity? And that's kind of where I'll transition into talking a little bit about my lab. So this is an article that we published in the American Journal of Public Health that articulated just needs for training the next generation of researchers that are focused on improving health outcomes for justice-involved folks. And basically all of the authors, except for one on the second article, are trainees in my lab that have worked at that intersection. And so for me, it's really become about like, you can't do this work by yourself, right? I've been a volunteer in the system since 2014. And even with the groups that I run and the half day to a little more than a half day that I do, you know, you just can't do as much as you need to or want to help. And so it becomes about how do you train people up to do it with you. And so I'm going to move on to kind of the journey that was the journey to my lab. And so folks may or may not be familiar, a lab just kind of refers to a group of people that are gathered together to do research, right? And so I started my lab during my postdoc year at UAMS. And to me, it was just such a feasible and familiar ways of facilitating multiple goals. So of course, you know, doing research and getting projects done, but also facilitating education, training, opportunities, and experiences for students. It was also for me a way of mentoring and building a track record of mentoring, which is something that's really important to me because I've just received amazing mentoring and I really want to pay that forward to other people. And when I originally had my lab, I actually had a different name before I had HEALS, and it was the Behavioral, Relational, and Intervention Science Lab. And this was really coming out of, you know, for me, a scope that was too broad. So what I noticed was that I had kind of a line of research that was on basic emotion and kind of laboratory kinds of studies. And then I also had my work on that was the intersection with the legal system. And I think one thing you might think about for yourself when you reach critical transitions is where do you spend your time when you don't have enough of it and you have too many opportunities? And I just noticed kind of over time, if you know, I had an hour to work on a paper, what I was going to work on was the research that was at the intersection with the legal system. If I had an hour to work on a practice-based project, I was going to try to get the stuff done related to my volunteer work at the prison. And so just paying attention to kind of your internal clock could be a piece of advice that I would give folks for how you might make some of those decisions. And so I changed my lab name and I made it the HEALS Lab, which stands for Health and Legal System. But I also really intentionally and possibly aspirationally on the last word focused on wanting to intersect research, practice, and policy. And so I've dabbled in a little bit of policy, but like I said, that's a goal for me to get there, is to really fluidly integrate all of these things. And so our mission is just highlighted up here on this slide. Really scope and goals wise is trying to help prisons, jails, courts, and other legal settings identify and meet mental health and substance use service needs of the people that they serve. And secondarily to study the development, adaptation, effectiveness, and implementations of interventions for trauma-related sequelae in legal settings. And very importantly, also to advocate for and directly facilitate direct provision of services. And so I think that's a model that I want to keep pushing forward, is that research labs, you know, really should have an impact in something real world that you're trying to kind of drive for. So, you know, who's involved in my lab? Me. I have a couple of staff. I have 2 coordinators and 2 REs. I've have several kind of longer term trainees that are around for placements that go on for some time. And then I occasionally have short-term trainees, depending upon my ability to kind of facilitate that at the moment, like summer placements. And then I also have people I would consider affiliates that help out with projects, but aren't necessarily in the nitty-gritty day-to-day, like clinical trainees, which is really exciting. And it just gives us a place to kind of like come together and do this work through weekly meetings, project check-ins, and providing training. So just kind of giving you a sense, we have a brainstorming meeting at the start of the semester. People kind of tell me what they want and want to learn, and we come up with what we're going to focus each lab meeting on. And so that way it's a training experience in addition to a research and project focused one. And so that goal is to really facilitate people getting the research experience that they need. A lot of the students that are in my lab want to go on to graduate school, and so they need research experience. They need help with products and getting like presentations, publications, things like that out. And then they also need help with professional development. So thinking through the graduate school process, how do you make these kind of key decisions? Help looking at CVs, developing professional writing, things like that. And so I'm very proud that I have published and presented with many, I would guess most of my trainees at this point. I really try to involve them. So like I said, you know, one of our articles earlier this year in the American Journal of Public Health, pretty much everyone on there was my trainee. And so we focus on that. One thing I'm really excited about kind of moving forward is I'm working on developing a community advisory board, which I don't know if folks have heard of those. I hadn't until recently. But basically it's a group of members that can be a voice for the specific community that research team is working with. And so working on developing a community advisory board that would be women who are formerly incarcerated. Where they could advise our research team on basically like, what are the important issues to you? How do we, like, what do you want us to look at? How do we reach you in a way that will support you, like post-release, things like that, where, you know, people that are directly affected are also having a role in setting the research agenda, if that makes sense. And so I will go into some specific research projects or examples, but I'm just going to pause here for a second, both because I've been talking a really long time and need a breath, and also because this is going to be a switch sort of in giving some illustrative project examples. So a little bit of a switch in topic to just see if anyone has questions so far from anything I've said on kind of the development side.
Why is Arkansas the last in mass incarceration among other states?
Mm-hmm. You know, I don't know the answer to that, and I wish I did. I mean, I think many things come back to policy, right? And so, you know, what are the decisions, you know, what do our laws say? Where are we policing? What are we choosing to enforce versus not enforce? I think, you know, jail is a point, like a lot of states are really focused on diversion programs. So trying to, you know, make it such that, you know, just because you come into contact with a law enforcement officer doesn't mean that you enter into the legal system. And then more diversion. So just because you, I don't know if folks know the difference between prisons and jails, but jails are typically a lot of the time, not all of the time, pre-adjudication, meaning you've been charged with something but not convicted. And then prisons would be post-adjudication. You've been convicted and sentenced and you're there for a period of time. And so jails represent another diversion point. So on that graph, right, that was looking at the prison population. So it is actually that we are sending people away with sentences at a rate that's double the next highest. So I would look to, you know, I can't speak to this, but wondering what judges are, you know, what's happening when people are prosecuted in terms of feeding into that.
You know, what I was wondering in the reverse of what was thinking was did Alaska have the largest decrease in its prison population?
Yeah. Again, I honestly, did I just unshare? I was going to try to make it so you guys could actually see me while we were talking. Okay. I honestly am not as familiar with Alaska's policies, but I again would look to, have they changed their laws and policies around like drug crimes, for example, is something, I mean, you've seen in some of the recent elections, right? Like Oregon is an example of decriminalizing drugs. Different places have made adjustments in what they're willing to sentence people to prison time for. Yeah.
I had a question.
Yeah.
Okay, sorry, I don't have my camera on because my connection's bad.
You are totally fine.
But from a legal perspective, I'm really interested in getting into policy and stuff like that. Have you done any research to see in Arkansas what is causing, like what specific policies? I know that's a very broad thing, but like, is it mainly drugs or just kind of?
To my knowledge, we've made very little adjustment in our policies, if any. So my lab is following.
Oh, I was just gonna say, hypothetically, if you could like create your policy of like, this is going to solve the big issues that I see in my research, like what policy would you advocate for?
I mean, I do a lot of very downstream research and practice where people, you know, have been, I think, not had their needs met for a very long time. I mean, I would go to prevention and intervention for trauma and early childhood. If I was gonna pick I'm doing what I know well and what I can do well, but I would move way earlier down the lifespan if I really wanted to affect, have the biggest effect on some of these outcomes.
I can speak to that.
Yeah.
Hello, everyone. My name is Corporal Porter. I'm with the University of Arkansas Police Department, and I'm also a criminology student.
Awesome.
So as far as the question that was brought up about laws and things like that, as far as there's federal law and then there's state law, the state legislature and stuff like that. So when it comes to punishable crimes, we're talking about crimes against the public. The latest thing that has made a difference in law enforcement, which is about 4 years ago, was lowering like a drug offense for a usable amount of marijuana increased to make it a misdemeanor. The amount was increased to make it a misdemeanor. It was lower, it would have been a felony. But anyway, they made it so that marijuana offenses that were of a certain amount were just misdemeanors, and they could cite and release on those aspects. But I feel like the nation is moving toward a more liberal aspect of drugs. And I hate to say it, but it's kind of like prohibition. One time is illegal, and the next, they're taking a look at it and making it, oh, it's not that bad, just because of the ramifications of putting someone in jail for a small amount of a drug concentration, an illicit drug concentration, as a felon would back up the court system and back up the jails. But I'm not saying that's right. That's what I see. Does that help?
Yeah, I think too, do you have any sense of what might be contributing to the increase? So that might be like a mitigation type policy, right? That might bring down the number of people. I feel less certain about what's contributing to the increase.
Well, apparently never mind. This is,
The increase of drug offenses?
The prison population in Arkansas has actually gone up 23% from 2012 to 2017. And I don't mean to put you on the spot. I was just curious. You have that applied experience, applied lens.
Oh, absolutely,
I wasn't sure
absolutely.
if you have seen. Yeah.
Dr. Ron's class last semester, and I can tell you that it was in the class. I'm gonna have to get back to you guys on that. There's some credible evidence, some evidence or some statistics that I could provide that that address that.
Mhm.
And I think it had to do with, nope, don't quote me. Never mind. I was going to say something, but I don't want to do that. Never mind.
No, that's okay. I just saw a question come through the chat box. So did the increase in incarceration influence you to target or help women affect in the community, or was it for a different reason? Yeah, so I would say that my awareness of that was a huge influence. So I came into this topic after that increase was well underway, right? So you saw that increase started in the 1980s and has gone up and up and up since, right? So I think it really, for me, it was that practice experience of, visiting a prison and providing a group therapy every week and every Monday night for about 2.5 years, actually, before I moved down to Little Rock, where you just realize that we have a lot of stereotypes and a lot of thoughts about what people who become incarcerated are like, and what I saw was a whole lot of people that I mean, frankly, I tell this the exact same way over and over. You hear the stories and the things that these women have lived through. And what I found myself thinking every week was, it was amazing that they are alive and standing up. And that's what sparked my passion for it, was, seeing this increase, but really hearing people's stories and going, if this isn't a population worth helping and in need of good care and expertise, like, I don't know what is. And so it was that for me. And so I think there's a lot of, one thing I would say is that it really is the population. Like I used that term just a second ago of people who become incarcerated. Like incarceration is like a state, right? You're incarcerated during a period of time. It's not your identity. And if there were ways to help this population in other locations, right, if they didn't become caught up in the legal system, if we changed our policies such that they aren't in prisons, I'd be, just as passionate about helping this population elsewhere. It's just that I know right now that if you have a good mental health background, and especially a good background in trauma treatment, you can pretty much walk into any prison and guarantee that you're going to have people that really need your services. And so if you want to make an impact, it's a way to.
As you said, you hear these stories of these women and no wonder it's crazy that they're still alive. And it can be pretty sad and challenging sometimes to be working constantly day in and day out in an environment like that. How do you, and if not how, what do you do to keep going, when you hit that low point?
Oh, that's a great question. I have a lot of thoughts related to that. I think having a strong professional network, mentors, colleagues, people you can talk to about it is really important. People that are like-minded about these issues and that you can just kind of be mutually horrified. But honestly, the other thing is I see so much hope in trauma treatment. And so it is sad and it is heavy. And we have treatments that really help people. Like from when I back up into my clinical psychologist hat and mental health hat, like we have treatments that work. And so on the other hand, while it's heavy and hard, it's also, I think, really hopeful and empowering to make these things available in settings that are not where people don't have access. And so that's a big part of it too, is it's reinforcing by nature, because you get to see people get better and for things to matter. And so I think I don't think I could do the research. Like I personally would not feel satisfied just doing research without the practice part of it. Yeah.
And what brought you to UAMS sorry, U of A from New Jersey, besides the research and the mentor? Like, what place brought you here?
I mean, I flew out to Arkansas not expecting to like it, honestly, and I just loved it. I don't know what else to say other than just like kind of an affective kind of reaction to the Northwest Arkansas area and to the people that I met with, and just how kind of like the feeling that I got, I guess, here. So, yeah.
Thank you.
Any other questions kind of on this side of things? On the, yeah, I see someone unmuting.
How are you putting together your CAB group, and how long do you think until that's like up and going?
Yeah, I'm really excited about this. We've been approaching it slow because I've never done this before. I'm hopeful that we'll kick off shortly after the beginning of next year. So we have an institute at UAMS, the Translational Research Institute. I almost blanked there. And they specifically have a team that's the community engagement team that's kind of helps people do this. A lot of times they help people put together a CAB for just like one study. So you're proposing a study and you want to kind of run it by some people that are affected. I think I'm maybe their first one where I'm like, no, I want one for like my program of research, like tell me what you want me to do, kind of CAB. And so we've been like creating the materials and going back and forth with them on like, how do you run a meeting? How do you frame out like what the purpose is? And I got to sit in on that Translational Research Institute. They have a CAB. I think they're the other area that has like a standing CAB that's active and advises them on their activities, like what kinds of programs to make available at UAMS. And so I will probably, in terms of like recruiting for it, I'm planning to start with the nonprofit that I used to work with because they've served a bunch of over 100 women who have been in reentry and kind of snowball from there. But there will be just basically like an interest meeting where we talk about what it is for anyone who's interested and what it would mean to be involved. We framed out sort of like an MOU, a memorandum of understanding or memorandum of agreement that'll kind of explain, here's what you're agreeing to, here's what we're agreeing to, kind of set some parameters around that. But yeah, that's the general kind of where we're at and idea. Okay. All right. I can talk research for a couple minutes just to give you kind of some examples of projects kind of at this intersection that we have going on. And I just picked a couple that I'm proud of. So one example is work that I've been working on to improve this is actually an area where I have moved into policy, but primarily practice and research knowledge around women who are incarcerated while pregnant. And so that's something that I became aware of down here. The facility I volunteer with is the facility in the state that houses women who are pregnant while incarcerated. And in this whirlwind of 2019, I'll kind of switch over to this next slide. Essentially, there was this is a residence idea. So a woman who was incarcerated talked to the deputy warden there basically and said, hey, like the pregnant women are getting depressed. We really should do something for them. I'd been at the facility as a volunteer for 2 years at that point, and the deputy warden pulled me out of class one day. I'll be honest that I thought I was in trouble because I had not talked to him all that much, and I got pulled out of the middle of class. I was like, oh gosh, what did I do? And basically he said, hey, you know, this is what's going on. Would you be willing to start a support group? And actually, Dr. Bridges, I think this is a you quote. I very much have been trained. You don't intervene where you don't understand, right? And I'm like, I've been coming here for a long time, but I've not done anything specific to pregnant and postpartum women. Like, I need to talk to them. Happy to do a support group. Like, I'm going to help you with this, but can I talk to them first? And so what we did was a series of listening sessions where I got to meet with them alone and do some brainstorming about, what their needs were at every phase. So during pregnancy, during childbirth, and after. And each week we would kind of take the feedback that the women had given me, and I would formalize it. I'd bring it in the next week and say, hey, this is what I heard us say last time. Is this right? And then I would feed it back to the leadership. And that was how we framed out the program, which and got it approved, which is a multi-component program. Like this slide mentioned, we launched a lactation program to allow women to breastfeed, to pump, and then have a caregiver pick up milk for their infant while they're incarcerated. This sadly has been on hold during COVID, but before that we had, between the launch of the program, we had 7 women that participated. And this is kind of an example where the practice happened first. Like I got approached like, hey, can you do this support group? And I said, wow, this is like, I don't know if they're going to ask anybody else. I need to figure out a way to do this. And it's really important. So, Arkansas has the 8th highest number of incarcerated women in the nation. And over 75% of incarcerated women of childbearing age are, or over 75% of incarcerated women are of childbearing age. And there was just a study that was done this same year that we launched that showed that about 4% nationally are pregnant upon intake. So this is not, it's an invisible population, but it's not, they exist. And, in Arkansas, we really had no knowledge on even basic information, like questions that I asked at first about like, okay, how many women a year are we talking about? How do they do? And so this is just, it struck me as like, well, we're going to do this practice, but we also need to get data. And so I was able to get funding for a pilot study that we're working on right now. It's a wild story and I don't have time to kind of go into it, but I learned down the line after this that my hospital actually provides the prenatal and postnatal care and that women come here to deliver. And so we have 5 years of charts that we can go back to and answer all the questions that I wish I had access to when we launched this program. So we're going to be doing a chart review to look at characteristics of women who have been incarcerated in Arkansas state prisons from 2014 to 2019, basically when the electronic medical record has the data for. And then we're also doing some things around intervention. So prospectively studying, so meaning enrolling women and doing data collection moving forward on kind of how things go for them, and looking at that as a function of their involvement in the Growing Together kind of program components. And we have been working for the past year. The thing we have been doing during COVID is trying to get all of the pieces in place to be able to pilot a childbirth support intervention where when women come to the hospital to give birth, they'll be able to have a doula support them. Normally they can't have anybody other than an officer in the room with them when they give birth. And so doula support is something that's been successfully implemented in 13 states as a way to be able to have women have someone who's essentially on their team in the room with them while they give birth. So we're going to be working on piloting that. So that's a good example of kind of, again, these research practice intersections that I think can be hugely impactful, if set up. I'll give you one more example. So this is more of now the research to maybe practice route. So I'm, a lot of my time is funded by a grant that is a career development award and allows me to take some time to learn as well as do research. And so the project that I'm doing as part of my career development award involves implementing an evidence-based trauma therapy in 2 other community correction centers in Arkansas. And so I've been working to identify factors that are going to influence the implementation and uptake of this evidence-based therapy called cognitive processing therapy in prisons, and basically using the interview data that I gained, that I'll show you what some of the questions we asked were in a second, to adapt CPT for people that are incarcerated, and eventually conduct a trial to see if it helps, if treating trauma while people are incarcerated helps them post-release in terms of both decreasing PTSD symptoms and also decreasing drug relapse. And so I'm working with 2 community correction centers up in Northeast Arkansas, 1 men's facility and 1 women's facility. And like I said, we're going to be implementing cognitive processing therapy. And the reason that I picked that was because there was good evidence that essentially like even lay providers can provide this therapy effectively. So there'd been some work done internationally in conflict zones that use people with high school level education or less and adapted the treatment to be able to offer it where it wasn't otherwise provided. And so, you know, so far on this project, we've done qualitative interviews with staff and residents. And the people in blue are representing staff members at each of the facilities, and the people in yellow are representing residents. So we've interviewed 32 people total about, you know, what they think of this therapy and what do they think are going to be the things that will help its implementation and what are the things that will get in the way, and have been working on creating a plan to implement. So this is very much informed by a field called implementation science. It's one that I'm focusing on learning a lot about, and one that if folks are interested in kind of these systems level interventions, you might look into. But basically we asked them a whole bunch of questions about this therapy and how the prison structure might affect implementation, how it compares to other programs they are already offering, what barriers that they saw to doing it, whether they liked it and thought it would be effective, things like that. And so we used that to pull together kind of our understanding of, you know, characteristics. So inner setting refers to characteristics of the facility itself, of the prison. And looking at, so like this is an example of what we're finding. So some of the barriers to implementing this therapy are things like, well, they have all this other stuff to do, not usually in very science terms there, but essentially there's a lot of things that go on in prisons. And so implementing this optional group might take a lower priority. They also don't have resources in terms of like staff time. There's a high programming burden and not a lot of staff. And then as you might expect, also things related to culture. So at the end of the day, these facilities are prisons, and there are rules that can be counter therapeutic or can be kind of, there's definitely power and control dynamics. And in these kinds of centers, which are actually licensed by the state as substance use treatment centers, there was this theme that came up over and over of kind of it being forced rehab. But we also are finding that there are facilitators that will likely help. And the biggest one by far is compatibility. So prisons have shifted, some of them, especially community correction centers, to offering some cognitive behavioral types of interventions where you really focus on changing thoughts and the things people do to help them change how they feel, help them change patterns that are getting in the way of their life. And I'll never forget the day I was doing these interviews in the men's facility, and I walked in and they had a mural on the wall that literally had like patterns of problematic thinking essentially painted on the wall, which is one of the intervention points in this therapy. So that's an example of compatibility where you see they're already teaching this. It's just a slightly different thing. And so I'm going to skip ahead. This is qualitative data that I've really boiled down, but a lot of what I'm doing in the background is trying to now use that interview data to adapt some of the materials that are typically offered in CPT. So one of the ideas one of the stakeholders gave me was like, hey, listen, this came up a lot in the men's facility. Hey, listen, you know, a lot of the guys can't read or have trouble with it, and they're going to be embarrassed. And they're not, you know, that could be a reason that they won't participate. And 2 people mentioned the idea of using shapes more so than words. And so like, here's an example of transforming a sheet on the left to one on the right that is more picture-based. And I've spent a lot of time on these sheets, transforming sheets that typically look really academic. And this is like on the left, a really well-tested tool in therapy to help people kind of change their thoughts. And again, integrating shapes in a way that we can, you know, help people have visual cues to what we're talking about. And in the treatment manual that I've adapted, I've even done some examples where people, like they're pretend examples because they're me, but I've drawn in responses as opposed to written in responses to kind of show how you could teach someone how to kind of draw if they can memorize. So this is again a more science to practice example of some of the kinds of work that we do, and we're working up towards doing a trial to assess if this therapy helps people post-release. And I'm excited. We're getting to install telecarts on Monday to be able to start engaging remotely. So it's kind of what I got in summary. I pulled this kind of quote as a good representation of, I think, what y'all, kind of the decisions that might hit you. This is kind of a good example of how I think about it. It's like driving a car at night. You can never see further than your headlights, but you can make the whole trip that way. And so it's about just doing the next thing, right? And having a destination in mind. So, you know, advice that I'd kind of give in closing: shoot for the moon, which may be scary and you may fail, and that's okay. You will fail, you know, we all will. But that really these integrations of research and practice and eventually policy can have an impact, but that you won't do that alone. So have lots of good partners and good team members. All right. So I am happy to take additional questions on either science or practice. But yeah, thank you guys very much for having me.
That was fascinating. Wow. Pretty good. Really good.
Smith has some questions on the chat.
Let's see. Okay, so what is CPT in practice for those that don't know? Yes, great question. How do I put it in a nutshell? Basically, when people go through traumatic events, it can really change the way that they think about themselves, the world, and other people, right? So you might have beliefs about, you know, that I am a strong person, I can take care of myself, I can trust other people, and then this traumatic event happens. And it can kind of either shatter people's beliefs about themselves, right? Like, so, well, this thing happened to me. Maybe I'm not as strong as I thought. Maybe I can't trust myself. Maybe I can't trust other people. Or it can cause them to go into self-blame so that they can keep their beliefs, right? Because, well, maybe it was my fault. And maybe I am, you know, I am as strong as I think, but I should have made it not happen. And so what CPT is, it's a talk therapy that helps people identify the kinds of thoughts that are keeping them stuck from recovering after PTSD. So you isolate kind of the ways that it's changed each person's thinking. It varies from person to person, and you help teach them skills to challenge those thoughts so that they can get to kind of more moderate thoughts where, okay, we're not going to pretend that the world is all sunshine and roses, right? It's not, and enforcing those beliefs would not be helpful either. But we have to get to this balanced place of bad things can happen in the world, and it doesn't mean that the whole world is bad, right? Or there can be people that you absolutely can't trust, right? And that will harm you if given the opportunity, and it's not everybody. And we really find that it's an evidence-based treatment for post-traumatic stress disorder, which is heavily linked to drug use, which is kind of, if we kind of look at the cycles of people becoming incarcerated, one of the reasons to focus on that is to try to see if providing trauma treatment will help people with their addiction, which will help them after. What do you say to people that ask why even give help to people in prison as they did bad things, and that's why they're there in the first place? Oof. Oh, that's there are so many layers there that intersect with values that make that even a hard thing to sum up. I mean, I think that first and foremost, if you defined any of us by the worst thing we've ever done, that's essentially what you're doing with that statement, right? And we'd all be in that boat. There's also a pretty awesome TED Talk. It's called "We Are All Criminals." I would encourage you guys to look it up. It's a photojournalist who went around and did interviews with people and identified a bunch of people that had all committed the same crime. And my understanding of the book, I've never seen the book, but there's a book that she put out that, thank you for putting it in the chat, that on one page on like the left-hand side, it'll have someone who committed a crime, same crime as the person on the right-hand side. One of these people was arrested and incarcerated, and it kind of traces out what happens to them in their lives as a result of that. And one of the points that she makes, just like the name of the talk, right, is we are all criminals. Like, I mean, how many people could really raise their hand and say that you haven't done something illegal ever? She uses the term, basically, what do you have the luxury to be able to forget if you haven't ended up in the justice system? Like, you get to forget that you did that, right? And you're not living with the consequences every day. And there are people that, you know, the way our laws are set up, you do your time and it's not over in most states, right? So I would say, you can't define people like that and just look internally, but I also just think it would be preposterous that they've done much in-depth work with people that have become incarcerated to think that way, because I stand by what I said earlier, just the level of trauma that the vast majority of people that end up in prison have suffered. I mean, it's a big deal that they're still alive. Okay, in your research part of the presentation, you mentioned that you collect qualitative data. Do you collect quantitative data as well? Is qualitative data valued more? Great question. I do mixed methods in almost everything now, because I think with qualitative data, you get this really rich look at kind of how people themselves define, right, their experiences and whatever phenomena you're studying. And then with quantitative data, you know, numbers can be really powerful. If you want to speak to prevalence, like, I mean, if you want to speak to how much a therapy helps, you know, numbers can be really impactful, but it's a whole lot more impactful when you see both, when you see kind of the lived testimony and numbers. So I get both. I would think, actually in a lot of areas of research, I feel like qualitative gets the short shaft, maybe more than quant, but it just depends on what field you're in.
Yeah, I asked that because a lot of the research that I have experience with values a lot of quantitative data. So when you kept on saying qualitative, I was like, that's interesting. Like they do get the shorthand of the stick. I agree. So I thought that was pretty interesting. And since you do use quantitative data, how do you use it? How do you get those numbers and those results?
Yeah. It's really a mix at this point. So it depends on like what your methods are for the study. So I use a lot of self-report questionnaires is, I mean, primarily how you would get like psychological symptoms, how I get like health service utilization. But I increasingly also use administrative records. So meaning like, I mean, I can get data from, like I said, like healthcare records where this is what was charted in the chart, and can pull from there. You can work with the Department of Corrections, Department of Community Corrections. They have an IRB. Any of my projects also go through that. It goes through the university IRB as well as the Department of Corrections or Community Corrections. And so they provide administrative data for some projects. Like if I want to look at incarceration history, for example, they have that in their database and they'll pull it for you. And so it's just it's a combination.
What is the best resource in terms of books, papers, articles for people who want to dive in deeper? Because as you said, you don't have all the time, but the work you're doing is fascinating. Mm-hmm. What do you want to say to us?
Yeah, I could get you a more complete list for folks that are interested, but I think that Wildman, so that this is not a book, it's an article, but where the graph of incarceration rates in the US was pulled from, it was Wildman and Wong's 2017 article that talks about some of the underlying impacts that mass incarceration has had on public health. I think that's a really, really important article. I mean, getting familiar just with the issue, like, I mean, the government puts out a ton of reports, like the Bureau of Justice Statistics, they have many, many reports that'll give you a sense of sort of like the systems level kind of changes in population and prison population. It just depends on what you're interested in. There are a lot of people doing a lot of good work to try to, especially like one area where there has been a lot of progress made is around opioid. Well, I say a lot of progress made. There's a lot of resources going into, and I think it's starting to translate into public health impact is medication assisted treatment and providing that to people before they leave incarceration. So another statistic that'll blow your mind, people that leave prison are 13 times more likely to die in the 2 weeks post-release than general population during that same period. And this is a combination of drug overdoses, violent injuries, so like either assaults or like traffic accidents that occur. And so that period is just so important. And with the opioid epidemic, there's been a lot to try to, and these are partnerships with these facilities, right? Like these facilities have to be the ones doing that work in partnership with people from a public health lens. Yeah, I think looking up information about that and what can be done there is another way to give you a sense of just, I mean, some of these things really are matters of like life and death, no matter what you think about the policies. And so I always struggle a little bit with just like not wanting to contribute to there being reasons to continue incarcerating people, and like because we can help better, but at the same time there are people sitting in these places right now that are at risk of dying when they leave right now. And so I've decided to do the work at that intersection while there's still that need, while hoping that we see some major system transformation.
Do you think the results that you're finding with your lab can be applicable to different groups of people, whether it's like people that are incarcerated in different countries or just different marginalized people here in America?
Yeah, I mean, I definitely think that anything related to implementation, like I've thought a lot about just, I think some of those same questions are really important around like rehabs, domestic violence shelters, homeless shelter, like any agency in which people are going to be like housed for a period of time. There are really practical considerations around like, okay, we have treatments that work, but there are certain parameters that make people more or less able to engage, like how long they're there, for example. And I think so if we can answer key questions about like what can work kind of in a short term, that that could be applicable. I think there also will be nuances, things that are, you know, different barriers and facilitators in different settings. I also think that even if the exact result is not necessarily generalizable, there are implications like outside of people in the legal system. So like one thing I'm finding, I have a study I didn't talk about that is following up with women like 3 to 5 years after they were incarcerated and looking at their receipt of services in the community post-release. And what we're finding with mental health services is that they really don't have any. And so that has implicated, like they have PCPs. So that tells me, okay, maybe primary care clinics are the place to go to try to help with this, but they don't have specialty mental health care. I'm also seeing increased risk for domestic violence post-incarceration as compared to before. And this is real small, but you have to think about if you kind of like pluck someone out of the community and they don't have a home, they haven't been able to save money for years, they're going to be potentially more at risk. So I think that, you know, again, incarceration is just a state that somebody is in for a period of time, and they will not be after some period of time. And so the work that I'm doing, I think, has implications for like how can we better meet the needs of people when they're in the community instead of having to access when people are incarcerated. Y'all ask such good questions.
It's your
Okay.
research is just so fascinating and so unique. Like if I had like the opportunity last summer to apply to your lab, I would have definitely done that over any other RU program. And that's what I was going to ask you about. Like, do you accept undergraduate students of any major, or is like, how would that process work for someone that is interested in your research?
Yeah, no, I have a lot of undergraduate students that I work with, and I for this summer for the first time took a high school student even. So I'm definitely interested in working with trainees. It's a matter of thinking what's possible via distance, and with kind of the pandemic has been part of what we've been adjusting to right now, because I'm very used to like being able to have people like physically here, and there are things around data security, right, that are important for the research piece, where you kind of can't, there are just limitations on what can be done from a distance versus what can be done if you're on a networked computer here. So I'm very open to it. I'm always open to kind of brainstorm with people about it. There are also things that like, I mean, I have people like I'm trying to figure out with part of the CAB, something I want feedback on is like, so a lot of our research goes into academic journals and never reaches the public, or doesn't for a long time. Like graphic design skills are definitely something I'm in the market for, like someone who can like think through the lens of understanding research, but going kind of creatively, okay, how do we take this like journal article and actually make like a little infographic that kind of like hits the key point that can get sent out. And that's something like to policymakers, to community, to it, like to anyone that would consume it. And that's definitely something that could be done from a distance. So I'm open to all kinds of kind of engagement that way.
You can definitely hit us up. This is like this is right up. If you just create a pipeline with U of A and UAMS, this would be done overnight.
Oh, I love that. Well, maybe we'll have to have a part 2 brainstorm about how to do that. Yeah.
Okay, real quick. What's your favorite book?
My favorite book. Ooh. Oh, I'm going to show how much of a nerd I am. I don't read a lot of books. I read a lot of journal articles. Gosh. I'm reading like 4 right now, all at the same time, because I decided that I was going to start reading again, and I'm like a chapter in on each. Like I said, I'm starting to think about like systems level stuff and professional development. So I'm reading some books on like creating change in academia. Real boring, but that's what I'm reading.
No.
So, sorry, I don't have a better answer to that.
Totally fine.
Yeah. All right. The other thing I'll just mention quickly, Alan, your comment made me think to mention this actually. So I try to raise awareness about this. I have a project related to it, not going to talk about it at all, but from a service lens. So there's something that was launched in Arkansas in they opened in 2018. In a couple different counties across the state. But another thing that's being done to help, it was originally intended to help with jail diversion, is called crisis stabilization units. And a lot of people do not know that we have these in Arkansas now. And I want everybody to know that we have them. Yeah, 4 now. They're all operational. So you have one. And it's actually like literally right behind the correctional center that I used to run the group in, downtown in Fayetteville. And so what these are is there's a 24/7 line that you can call if someone's experiencing an acute kind of mental health crisis, and the law enforcement know about them and will transport people there at times too, but they're really short-term, more specialized alternatives to the ER that are intended to help people with mental illness get crisis care. And so again, a lot of people don't know about them. They exist. They're really great resources, and people should know that they're there.
I took the, it was a statewide initiative that said 25 or 22% of every police department has to have a trained crisis intervention personnel. And I took the class, and I was even there when they opened it over there in Fayetteville. It's
Yeah.
wonderful place. Now, I know that it was a 7-bed or something like that. And it was specific to law enforcement, but soon it should be open to anyone. I'm not sure if they made that transition yet, but yeah, I know exactly what you're talking about.
Yeah. Yeah. That's ours has opened, and I think are like open to not only law enforcement, but you're right, there was some staggering there. And that's a good question if Fayetteville's has or not. But the good news is they have people that will answer the phone 24/7, and so it can't hurt to call if you find yourself in a situation where you're around someone that might need that. It's a good service to know
This is
about.
good to know because not everyone who's causing an issue has the intention to commit a crime. It could be something else. And then that training helps you observe that and realize that.
Yeah, yeah. Yeah, and reactions that we all have to in the moment kinds of things are influenced by our life experiences, by trauma, you know, and I think, yeah, that CIT training is so important. That's awesome that you did it. Really important. So,
Well, I don't want to
yeah.
a lot of people's other times because as people have had to leave for other meetings. And I also respect your time, you coming here and giving us a wonderful talk. This was fantastic. Thank you so much.
Thank you very much for having me. It's been a
Yes.
pleasure, y'all. Thank you very much. All
Yes.
right.
Yeah, everybody truly, I mean, everybody saying thank you. Alex and Fa had to leave for other meetings, but on behalf of them and the entire Honors College and the University of Arkansas, we couldn't be more grateful for, you know, your honesty, openness, and like every question, you were like, wow, this is good. And you know, you're not trying to shorten it down. You were giving out a full thought out answer. So I appreciate you doing this and a great presentation as well.
Yeah, absolutely. So nice to meet everybody. Take care. Be safe. All right. Bye, y'all.
This is my first meeting with a university or University of Arkansas personnel that is not orientation, so that's good.
I'm glad that I could serve that role for you. All right. Bye, y'all.
Bye.
Bye. As always, encouraging